Morning, everyone. Today, we're going to be discussing massive irreparable rotator cuff tears. We're going to use Nearpod a little bit. So if you have that, you can pull it up. I'll have the code on all the slides in case you lose it. Our objectives to review rotator cuff anatomy and its importance in its function and healing, define massive irreparable rotator cuff tears, discuss the available treatment options, and synthesize the available data into a more formal guideline for the treatment of this condition. We'll start out with some cases, get into the background of the disease, discuss the both non-operative and operative treatment options, discuss a treatment algorithm, and then revisit our cases. So to start out, our first case here, our first patient is a 56-year-old male who fell a month ago and continued to have right shoulder pain, limiting his function. He has a past medical history, interestingly of OI, although he has not had any fractures here. On exam, he has forward flexion to 80 and internal rotation to low lumbar level. Passively, he has full range of motion. His strength is significantly diminished, and he has a positive drop arm test. These are his x-rays that don't look particularly abnormal, maybe a slightly narrowed acromiohumeral distance. And then it's MRIs showing full thickness, massive tears of all of his rotator cuff tendons, except for the leading anterior edge of the supraspinatus. There's not a severe amount of atrophy, but particularly in the teres minor, there is atrophy and fatty infiltration. Also on the axial, there's some posterior subluxation of the humeral head, and the long head of the biceps appeared to avulse and retract distally. So what do we want to do here?
While people are doing that, can I make one comment?
Of course.
So it looks like the subscapularis is not torn, at least on that one axial image, and the biceps is sitting in the groove. So you said all the rotator cuffs were torn. The other, looking at the sagittal, you can't tell that the infraspinatus is torn. I mean, you can only tell the supra is. So you're not giving us enough of an image to see that.
Yeah, sorry, these are limited slices. Didn't want to have to overwhelm everyone with 4 videos, but take my word for it.
Well, the radiologists are oftentimes misleading. So, I mean, I take your word, but I'd like to verify. The other thing is that you didn't mention there's a lot of edema, as if there is some acuteness to this.
There's a month out.
Well, it's a month out that he had the injury. A lot of people come with an acute on chronic, and you know, one of the issues you're asking us is what to do, and it really hinges on acuteness and chronicity of it.
All right. So we've got a pretty even split right now between therapy with or without an injection, a reverse, and a tendon transfer, with a couple people saying repair. So let's move to the next one. We'll come back to those later. Next patient's a 72-year-old who had no acute injury and has just had continued chronic left shoulder pain and weakness. That's worse at night, worse with overhead activities. He has active range of motion that's limited by pain, and full passive range of motion, substantially weak. These are his x-rays. I apologize for the red line. I couldn't get rid of it. But he has superior migration of the humeral head with acetagularization of the acromion, as well as substantial AC joint arthritis. These are some representative cuts from his MRI showing a full thickness, large retracted tear of the supraspinatus with the remainder intact and no fatty infiltration. All right, so most people here saying therapy with or without an injection, a few people saying reverse, a few people saying repair. Our next patient is a 77-year-old male, also with left shoulder pain that was aggravated a few months ago from a fall. Had no improvement with physical therapy. On exam, he had a similar exam to the prior patient with limited active range of motion and strength. On his MRI, it showed a full thickness retracted supraspinatus tear with a partial thickness infraspinatus tear and mild atrophy. So what are we thinking for him? All right, so we're getting pretty even split between more therapy and injection, repair, and reverse. And then our last patient is a 65-year-old female with right shoulder pain for a number of months, had a prior rotator cuff repair 18 years ago, has not improved with therapy. Similar exam with a positive drop arm on empty can test. On the MRI, it's difficult to see the full extent of the tear due to artifact from the prior implants, but you can see that there's a full thickness retracted tear of the supraspinatus and possibly the subscap, although it's difficult to see over there, and there's minimal atrophy. So most people here are saying reverse. Some people are saying repair, and then one person said superior capsular reconstruction. All right, so that's the end of our polls. So as you can see already, there's substantial variation, treatment strategies for these injuries. So we'll get into the background of understanding why it's such a challenging problem for some people. In terms of the anatomy, the rotator cuff, or the rotary cup, as many of our patients refer to it, is a group of muscles and their respective tendons that center the humeral head and the glenoid and help to provide dynamic stability to assist in shoulder range of motion. The components include the supraspinatus, infraspinatus, teres minor, and subscap, which attaches to the lesser tuberosity, and this separated by the long head biceps tendon within the bicipital groove between the subscap and the supraspinatus. Along with the capsule, the coracohumeral ligament, and the glenohumeral ligaments, the rotator cuff forms a confluent insertion on the humeral tuberosities. That's approximately 2 centimeters in width along the insertion. The roof of the rotator cuff is the coracochromial arch, whose morphology has been classically implicated in the development of rotator cuff disease. So Bigliani originally divided the acromion into 3 types that included flat, curved, and hooked. Type 3 or hooked acromions have been shown in many case series to cause impingement on the cuff, and some studies have demonstrated increased risk of cuff tears with this type of acromion and a worse response to conservative management. Between the rotator cuff and the acromion lies the subacromial bursa, which facilitates gliding of the rotator cuff. However, inflammation within the bursa is frequently encountered with rotator cuff tears, and bursectomy is frequently performed at the time of surgery. At the microscopic level of the rotator cuff, it's also important to understand the organization of the tendon. There's 5 layers of the tendon, with the bursal sided layers being 2 times stronger than the articular sided layers, helping to explain why most of the tears we see start out articular sided. The vascular supply comes from the subscapular, suprascapular, and humeral circumflex arteries and lies primarily within the second and third layers, primarily on the bursal side. And some important features of the cuff include the rotator interval, which is composed of the capsule, long head biceps, superior glenohumeral ligament, and coracohumeral ligament that bridge the gap between supraspinatus and the subscap. The rotator cable is a thick bundle of fibers that runs along the avascular zone and spans the insertions of the supraspinatus and infraspinatus. And the rotator crescent is the sheet of tendon distal to the cable, inserting onto the greater tuberosity. The overall prevalence of rotator cuff tears seems to be somewhere around 30% in the general population. That increases as people age. Multiple studies have been performed to try to evaluate the presence of rotator cuffs, both in cadavers and asymptomatic volunteers. In those cadaveric studies, they've been shown to have a partial prevalence of partial thickness cuff tears in about 13% and full thickness in 5 to 17%. And those over 60 years have a substantially higher prevalence of about 30. MRI and ultrasound studies in asymptomatic volunteers have shown rates of full thickness tears around 15% that increase exponentially with age to over 50% in patients people over 80 years old. The pathogenesis of rotator cuff tears is multifactorial. It can be caused by repetitive microtraumas in athletes who perform overhead motions or forceful pulling, such as pitchers, quarterbacks, firefighters, rowers. Younger patients who sustain a shoulder dislocation typically tear their labrum, whereas a majority of older patients with shoulder dislocations sustain a rotator cuff tear. Despite these possible etiologies, the majority still are chronic degenerative tears in older patients. There are a number of risk factors that have been linked to rotator cuff tears. Smoking has been shown not only to increase the risk of tear, but also is implicated in larger tears, inhibiting healing and worse surgical outcomes. Hypercholesterolemia has been implicated, and as has genetics. In terms of diagnosis, patients with symptomatic rotator cuff tears will frequently report an insidious onset of pain, but they might, as Dr. Kirschbaum mentioned, think that they had an acute injury, whether that caused the tear or aggravated it. Frequently, the pain is worse at night, which is generally a poor prognostic sign for non-operative management. On exam, they'll have weakness to resistive active motion that corresponds with the affected tendons. They should have intact passive range of motion unless they've developed an arthropathy, and could even have increased passive external rotation if they have a full thickness subscap tear. Subscap tears can be provoked with an internal rotation lag sign, lift off or belly press test. Supraspinatus tears are evaluated Job's test or drop sign. Infraspinatus can be isolated with external rotation lag, and teres minor with the hornblower test. And the accuracy of the exam can also be improved with a subacromial lidocaine injection, as previously shown by a former resident here. X-rays are often normal in patients with rotator cuff tears, but may also demonstrate calcific tendinopathy or proximal migration of the humerus. The acromion can also be evaluated for its morphology. However, MRI remains the gold standard for evaluating the tendon itself, and can help demonstrate the size, shape, and degree of atrophy and retraction of the tear, as well as the status of the biceps tendon and any other intra-articular pathology. Ultrasound can be used to diagnose rotator cuff tears as well with similar accuracy, but it's more user-dependent and can't evaluate for other intra-articular pathology. There's no widely used formal classification system for these tears, so it's largely descriptive. Descriptions generally include which tendons are involved, whether the tear is bursal, articular, or intratendinous. They can also be graded on their size, with massive tears being defined as being over 5 centimeters wide, including at least 2 tendons. The shape of the tear has implications on surgical technique and are frequently described as either crescentic, U-shaped, or L-shaped. Chronic tears can be graded by the amount of atrophy and fatty infiltration. And also the Hamada classification can be used to describe superior humeral head migration and glenohumeral joint narrowing. In terms of the natural history of rotator cuff tears, this is extremely important in deciding how to treat them. Yamaguchi evaluated the contralateral shoulders of patients with symptomatic rotator cuff tears I found that over half of those who had asymptomatic tears at the time of initial evaluation went on to become symptomatic at an average of 3 years. And in addition, half of those newly symptomatic patients demonstrated increases in their tear size compared to just 20% who remained asymptomatic. Aside from those whose tear sizes increased, no tears decreased in size or healed during the follow-up period, demonstrating the low capacity for healing, whether patients have symptoms or not. Determining why some tears become symptomatic and others do not is a much larger challenge. Some have hypothesized that the glenohumeral kinematics can be preserved in the setting of a cuff tear, as long as the force couples are maintained about the glenohumeral joint. And thus, tear location may actually be a more impactful factor on symptoms than the tear size itself. And additionally, superior migration in the humeral head appears to be more common in the symptomatic tears. Meanwhile, despite 25 to 50% of symptomatic full thickness tears progressing in size within a few years, many of these can be successfully managed expectantly, with about 60% improving without intervention. Among those who have pain at final follow-up, the majority have had tear progression. Despite those trends, determining who will do well without intervention and who will require intervention still remains a difficult problem. And then on top of the short-term functional concerns is also the risk of development of cuff tear arthropathy in the long term, which has been shown to occur in up to 74% of full thickness tears with 2 decades of follow-up. And those patients have worse functional outcomes. Moreover, the more tendons that are involved in the tear, the faster the arthropathy progresses. Then, even if a cuff tear is repaired, healing rates are not particularly high. Using data from a randomized controlled trial in the UK, cuff integrity 1 year after rotator cuff tear was evaluated by MRI in over 200 patients. The overall healing rate was found to be only 56%, and patients with larger tears and older age were found to have even much lower healing rates. This was, of course, confounded by the fact that older patients tend to have larger tears, but the effect of age remained even when they adjusted for this. So in their analysis, the youngest patients with the smallest tears showed healing rates still only at 75%, and those elderly with massive tears were as low as 17%. So why don't these repairs heal is the big question. And are the patients being too active postoperatively? Are the materials that we're using of poor quality? Are we just doing a bad job as surgeons? Possibly, but it really comes down to the biology. So first of all, tendons in general have a low potential for healing compared to other tissues in the body. They're relatively acellular and avascular. While the intact rotator cuff does not come into direct contact with the glenohumeral joint due to the capsule, the torn rotator cuff becomes bathed in synovial fluid, which further limits healing. In addition, cuff tears frequently go untreated for years prior to surgery. And with increasing time, the quality of that remaining tissue deteriorates dramatically, making the suture tendon interface a weak point of any construct. And as if that's not enough, the bone quality at the rotator cuff footprint is not always sufficient to maintain suture anchors or bone tunnels, particularly in older osteoporotic patients. And then even when the healing does occur, the bone tendon interface is disorganized and less resilient than a native tendon. As if that decision-making process was not hard enough with their limited potential for healing, this becomes even more difficult when you have a tear that's deemed massive and irreparable. In addition, although up to 30% of all rotator cuff tears have been reported to be irreparable, our ability to accurately predict that and determine which ones are repairable and not, based on our preoperative exam and imaging alone, remains imperfect. And even if a tear is technically repairable, this does not always translate into positive clinical results. Some preoperative findings that increase the risk of a massive tear being irreparable or a repair failing include size greater than 5 centimeters, 2 or more tendons involved, substantial retraction, fatty infiltration, static superior humeral head migration, absent acromihumeral interval, advanced glenohumeral arthritis, chronicity of the tear, and advanced patient age and comorbidities. So let's dig into the treatment now. In many individuals, particularly the lower functioning elderly patients, non-operative management of irreparable tears is the preferred first-line treatment. given the baseline irreparability of these tears, there's really little risk in delaying surgical intervention, except for the development of cuff tear arthropathy in the long term. The mainstays of non-op treatment include therapy, medications, and injections. Therapy is primarily focused on deltoid and can either include a self-administered home program or a formal therapist-guided program. Usually starts supine and progresses to upright over the course of a few months. The most frequently utilized medications are NSAIDs and oral steroids. Subacromial injections with or without lidocaine or steroid are also often employed, though there's theoretical consequences on the joint and soft tissues if you use a steroid. For those in whom non-operative treatment fails or is not suitable, there are a variety of surgeries that have been described for the treatment of irreparable cuff tears. Those include arthroscopic debridement with or without a subacromial decompression, biceps tenotomy, or tuberoplasty, partial repair, graft interposition, musculotendinous transfers, subacromial spacers, superior capsular reconstruction, and reverse total shoulder arthroplasty. So we'll visit each of these techniques and the existing data reported for each of them. So a 2008 prospective study from the UK sought to evaluate the results of a self-administered anterior deltoid re-education exercise program in elderly patients with massive cuff tears. They enrolled only 17 patients with an average of 80 years, all with confirmed massive cuff tears and limited function from shoulder pain. All of them received a subacromial injection with lidocaine and a steroid for initial pain relief, and then were sent home with an instruction sheet for their exercises. After 9 months, the patient's constant scores improved from 26 to 63, and their forward flexion increased from an average of 40 to 160 degrees. Only 3 of the 17 patients went on to have surgery. This study, while is limited, claimed that conservative measures can have substantially positive effects in the midterm for these elderly patients with massive tears. However, the cohort size was small, follow-up was short. They had a concomitant steroid injection, and we had limited reports on the actual functional outcomes for them. In 2017, a group from California wanted to compare their results with the deltoid re-education with the former study. 30 patients were prospectively enrolled, and the patients were given the same home exercise program. However, in this cohort, only a third of the patients received a subacromial injection, and they defined failure of the program as either abandoning the program for surgery or a less than 20-point increase in the American shoulder and elbow surgeon score at final follow-up. At follow-up, only 21 of the 30 patients had been compliant with the program due to pain and persistent symptoms, and 5 of the non-compliant patients and 3 of the compliant patients went on to have surgery, leaving only 18 patients who actually completed the program. And then 6 of those who did complete the program didn't have adequate improvements in their ASES score to count as a success. So overall, they reported only a 40% success rate. Overall, they were not able to replicate those results of the prior study. And although 40% were treated successfully, there was a high non-compliance rate and a high rate of crossover to surgical treatment. This study was too small of a cohort with no control group to say that this was definitive, but it certainly suggests that this is not the right treatment for everyone. A systematic review recently aimed to summarize the available data on non-op treatment. They had 10 articles in their study, including mostly case series. The most common definition of irreparable tear was 2+ tendons with atrophy and retraction. The average age was 69 years. They had a wide range of reported successful treatment, from 32% in one study to 100% in another. Factors that they found contributed to treatment failure included a lack of external rotation pre-treatment, atrophy, suprahumeral head migration, and glenohumeral arthritis, as well as a torn subscat. The average increase was 40, and forward flexion was 49 degrees, though this also had substantial variation. And the studies that got post-treatment MRIs found decreased acromial-humeral intervals, progression to arthritis, and increased fatty infiltration in the remainder of the cuff. So there's substantial limitations from this, especially because of the quality of the data that was included. But overall, it does demonstrate that non-op management could be successful with the right patient selection. So moving into our operative management strategies for patients who either fail non-operative management or are deemed not suitable for that. The first would be arthroscopic debridement with or without an adjunctive procedure. There was a 1999 retrospective case series from France where they identified 210 patients who were taken for arthroscopic debridement of their cuff tears at least a year of follow-up. The vast majority underwent both an acromioplasty and a debridement of the tear, and about 20% a long head biceps tenotomy. They evaluated the pre and post-op constant scores, as well as modifiable and non-modifiable factors, and found that the constant scores improved from 38 to an average of 67 at final follow-up, with greatest increases seen in pain and the level of activity. Some variables that portended a worse outcome were chronicity, younger male patients, workers' comp, and pre-op arthrosis. They also found that when more tendons were involved, they had worse post-op constant scores. When you isolated just massive tears in their study, they found reliable improvements in pain, but very little improvement in physical activity, range of motion, and strength. They also demonstrated a slower recovery process in these people. While this was a low-powered study with no control group, it did show that patients with massive tears are unlikely to recover a substantial amount of function with this limited procedure, although it might be substantial enough for pain relief. Another French group performed a retrospective review of 68 patients with an average age of 68 years who had 72 irreparable rotator cuff tears treated with an arthroscopic biceps tenotomy or tenodesis alone without acromioplasty. All shoulders had pathological lesions in the long head biceps, and about half got tenotomy and half got tenodesis and were followed for 3 years. At final follow-up, 78% of the patients were satisfied. The constant scores increased from 46 to 66, with the largest increases being seen in pain and activity. And the scores did not differ between the tenotomy and tenodesis groups. Interestingly, there was also no difference with acetabularization of the acromion. Active flexion was the only motion that improved. It went from 132 to 155 degrees. Otherwise, there was no changes. And patients with preoperative pseudoparalysis did not recover any motion at all. They found that external rotation was better in those with an intact teres minor. 60% of the tenotomy patients developed a Popeye, but none reported being bothered by it. So overall, they showed that the biceps tenotomy or tenodesis can be suitable for pain relief as well. However, the indications have to be picked carefully, and any arthropathy or pre-op pseudoparalysis appeared to have a negative results. A retrospective study from Korea in 2011 reviewed a cohort of their massive rotator cuff patients who underwent an arthroscopic tuberoplasty, in which the tuberosity is shaved down with a burr to create a more confluent articulation with the acromion. The vast majority of those patients also got an acromioplasty at the time of surgery, and they were followed for 2 years. At the final follow-up, the constant scores improved from 47 to 70, and the UCLA shoulder score went from 15 to 27, and patients with low pre-op acromiohumeral interval measurements were found to have substantially lower scores. Interestingly, there was no difference for patients under and over 65 years old. Forward flexion improved, but the other range of motion did not. And the average acromiohumeral interval did not differ from pre-op to post-op. Overall, like the acromioplasty and the biceps tenotomy or tenodesis, it seems that the tuberoplasty can be effective for pain relief in this population and lead to mild improvements in function, but primarily they're not increasing range of motion substantially. Increased success with greater preoperative acromiohumeral interval is important, as it suggests that the blunted humeral kinematics in these patients are still relatively maintained. The same group as the prior study performed a review of their tuberoplasty patients with at least 7 years of follow-up, and they found improvements in the constant UCLA and the visual analog scores that were sustained at final follow-up, albeit with slightly lower constant scores than their prior series. They also had modest improvements in forward flexion like their prior series. So up to this point, the non-operative and operative treatments described seek to improve pain and activity level, but they do not replace the function of the rotator cuff. So starting with partial repairs, the remainder of the treatments we'll talk about either recreate all or a part of the rotator cuff's function or circumvent the need for it entirely. The partial repair was first described in the early 1990s as a way to theoretically convert a non-functional rotator cuff tear into a functional one by restoring the force couples about the glenohumeral joint. The idea is that some repair is better than none, and many authors had reported good outcomes with these procedures. There are a number of techniques that can be used to facilitate a partial repair. Anterior interval slides involve release of the supraspinatus from the rotator interval, effectively incising the coracohumeral ligament, and that enhances the mobility of the supraspinatus and increases the possibility of repairing it to the tuberosity. Posterior interval slides release the supraspinatus from the infraspinatus with similar improvements in mobilization, but may in theory devascularize the supraspinatus tendon. When these slides are performed, the margins are often reapproximated or converged to reduce the tension on the repair. In addition, the cuff footprint can be medialized up to 10 millimeters from the original location if repair to the anatomic footprint can't be performed without undue tension. Subscap repair, while technically challenging, has also been reported to improve internal rotation and decrease pain. And regardless of which tendons are able to be repaired, care should be taken not to overtension the partial repairs, as that can lead to early failure. The partial repair can also be combined with a number of other procedures. However, it can be like a subacromial decompression or biceps tenotomy. It could also be combined with more synergistic procedures like a balloon spacer, superior capsular reconstruction, which aim to further restore the anatomy. A group from Taiwan retrospectively reviewed 37 of their patients who underwent a partial repair and followed them for an average of 30 months. All the patients were told pre-op that a complete repair would be attempted, but if not possible, a partial repair would be performed. They did exclude patients with subscap tears and those with hematogrades 3 or higher. Biceps tenotomy or tenodesis and subacromial decompression were performed as needed. They found that the ACES score improved substantially across the board from an average of 45.9 to 78.6. And this was particularly evident in patients with low pre-op scores and those with pre-op night pain. Thus, pre-op symptom severity did not impact post-op outcomes. The acromial interval didn't change from pre-op to post-op. Interestingly, all patients had a follow-up MRI of 6 months, and 41% of them had a larger defect at that time than was measured following repair intraoperatively. However, there was no difference in outcomes between those with an intact and failed repair. So overall, they found that they had good outcomes with a partial repair. However, the exclusion criteria of no subscap tears and no hematograde 3 or higher, as well as the retrospective design, make these outcomes generalizability limited. A group from Germany evaluated a series of 38 of their patients who underwent partial arthroscopic repair for massive tears. They excluded any patients with glenohumeral arthritis, irreparable subscap tears, and superior humeral migration. Follow-up was for 4 years, and all patients underwent a concomitant subacromial decompression and tenotomy. 4 patients had a supraspinatus that was not able to be repaired at all, and they received a tuberoplasty. At final follow-up, the mean constant score increased from 56 to 71, and when adjusted for age and sex, from 63 to 90%. Only 9% of patients had a score qualifying as a poor outcome. The pain, ADL, and range of motion subscores all improved to be similar to the contralateral shoulder, and forward flexion and abduction increased to be similar to contralateral shoulder. The average acromial interval trended towards a decrease, but did not significantly decrease. So this study found good results overall with this procedure. It's interesting that external rotation did not improve despite all the infraspinatus tears being repaired. In addition, there was substantial variation in the techniques that they used, making it a bit of a heterogeneous group. South Korean group sought to evaluate outcomes 2 years out for 31 patients of theirs with cuff tears that underwent a partial repair with at least 1 centimeter of humeral head remaining uncovered. They had 1 and 2 year follow-up. Pain, visual analog score, ASIS, and simple shoulder test scores all improved significantly from pre-op to 1 year, and were maintained at final follow-up at an average of 40 months, with the exception of pain, which increased from 1 year to their final follow-up. The acromial-humeral distance decreased slightly. Strangely, despite the increase in outcome scores, half the patients either felt the same or were dissatisfied with their results, with only 1 patient being very satisfied. The study, in contrast to the previous studies we saw, showed that a large cohort of patients with partial repairs will actually deteriorate in their outcome, even though their average scores will improve. Another option, if a rotator cuff cannot be completely repaired, is to augment a partial repair with a graft. The goal of graft augmentation is to fill in that remaining defect in the rotator cuff, and then serves also as a spacer between the humeral head and the acromion, decreasing tension on the repair and possibly increasing the healing potential of the cuff by performing a scaffold for cellular repopulation. The types of grafts available are numerous, including xenografts from pigs, synthetics like polycarbonate and polyurethane, fascial autografts, dermal allografts, and long-head biceps autograft, with the last 2 being used more frequently. However, there are many different surgical techniques and protocols that have been suggested, making it challenging to determine if one is superior to the other. A group in South Korea compared their cohort of 37 massive tears that were augmented with long head biceps to 31 similar massive tears that were repaired completely with maximal tension. They utilized biceps graft that was tenotomized as close to the glenoid as possible and then incorporated into the repair. Importantly, the 2 groups had similar rates of fatty degradation. All the patients had an MRI at least 6 months after surgery. At final follow-up, visual analog pain scores and range of motion in all directions improved significantly in both groups and did not differ between the groups. Muscle strength was better in forward flexion, external rotation, and internal rotation, and the constant UCLA scores improved similarly. In addition, re-tear rate increased with increasing fatty degradation preoperatively to nearly 100% if they had a score over 2. Overall, 41% of the graft patients had re-tears compared to 73% in the complete repair group. This study suggested that massive tears with undue tension may be more likely to re-tear compared to those with a partial repair and augmentation from graft. In addition, the augmentation appears to lead to better shoulder strength despite similar functional outcomes. Another group retrospectively reviewed 35 patients augmented with biceps tendon. All of them failed conservative management first, and a complete subscap tear was excluded from their study. They differ from others in that they did not tenotomize the biceps tendon, but rather incorporated it with the glenoid attachment intact. At final follow-up, there was no change in acromial-humeral interval. The average scores all improved significantly, as did range of motion in all areas except for external rotation. 4 of the 35 patients required revision and surgery, and full healing was seen in 63% on MRI, in addition to 20% with partial tears and 17% with full thickness. While these results were good, all of these patients had an intact biceps tendon and subscap tendon, which is often not the case for the massive tears, and it's difficult to generalize these broadly. A Greek group reported on 68 patients who underwent augmentation with a fascial allograft and were followed prospectively. They found that all their patients had stage 3+ fatty replacement on their pre-op MRIs, and most of the patients had post-op imaging, but about half of them did not agree to post-op MRI because they were too happy with their results. At final follow-up, they reported constant scores improving from 32 to 88, with the greatest increases seen in pain and strength. And on the post-op MRIs, they found that the repair interfered with the ability to visualize healing. So they did ultrasound instead and found a 10% re-tear rate. So the authors here reported substantial improvements in outcome with their technique. However, the study was pretty poorly organized and only reported on constant scores and re-tears from ultrasound. So it's difficult to take this at face value. A team from the UK prospectively followed 13 patients who they performed an isolated partial repair and 13 whom they performed a partial repair with a dermal allograft. All the patients underwent non-op treatment first and failed. All of them had a confirmed supraspinatus and infraspinatus tear with retraction, and the average gap after the partial repair was 2 centimeters. Everyone received an acromioplasty and was followed for 2 years. At final follow-up, both the Oxford shoulder scores and constant scores improved substantially in both groups. However, the group with the allograft augmentation had significantly more improvement than the partial repair group. The graft augmentation group underwent ultrasound evaluation at 2 years that showed a 30% re-tear rate. However, the tears were all less than 1.8 centimeters and did not affect the measured functional outcomes. So while this was a low number of patients recruited and non-randomized, the prospective nature of two cohorts makes it of higher quality than most of the other studies we see, and their findings did support use of a graft augmentation when a partial repair is performed. A 2017 study from South Korea compared their series of irreparable cuff tears, which included 24 patients with a long head biceps augmentation and 8 patients with allogenic dermal patch graft. The dermal graft was only utilized when the long head biceps was already completely ruptured, and also because they were commercially available in sizes larger than 4 millimeters. When long head biceps was utilized, the tendon was tenotomized from a splenoid insertion and then incorporated into the repair. At initial evaluation, the biceps group had significantly fewer subscap tears and significantly more fatty degeneration of the teres minor than the other group. At final follow-up, the long head biceps group saw significant improvements in all the VAS, ASIS, and quick dash and shoulder motion in all directions, while the dermal patch group saw improvements only in visual analog score. However, there were no significant differences in any category at final follow-up, likely due to the small sample size in the dermal group. Interestingly, acromial humeral distances actually improved in both groups, which had not been previously reported in other studies. To my knowledge, this is the only study to directly compare biceps autograft to dermal allograft for graft augmentation. However, it's severely flawed in that the dermal graft group had significantly more subscap tears and teres minor atrophy pre-op, thereby limiting our conclusions. The remaining treatment options that we'll talk about includes starting with the musculotendinous transfers aimed to replace rotator cuff function artificially. So the goal of a musculotendinous transfer is to restore the force couples to the glenohumeral joint without having to rely on a fragile repair of degenerative cuff tissues. There are 2 primary types of tendon transfer, including a lat and a pec major. The lat transfers are performed to replace the function of the posterior superior cuff. However, it lies in close proximity to the radial nerve and posterior branch of the axillary nerve, making a theoretical risk of nerve injury. In addition, the vector of pull of the lat is more vertical than the native cuff, and there are concerns that this can lead to abnormal kinematics and eventually arthritis. This is contraindicated with a non-functional subscap. Lower trapezius transfers have also been suggested for irreparable infraspinatus tears because their vector of pull is in line with the native infraspinatus, but that limited excursion of the muscle there requires an allograft bridge. Pec transfers are performed to replace the subscap and are preferentially transferred under the conjoint tendon to more closely replicate the vector of forces. The musculocutaneous nerve is at risk with that procedure, though. Advantages of the tendon transfers include their autologous nature and the intact muscle tendon unit as compared to the degenerative rotator cuff tissue or graft. Disadvantages include the technical difficulty, long rehab process, and limited long-term follow-up. It should only be performed in younger patients, really, without glenohumeral arthritis who can comply with the post-op protocols. A group from Switzerland followed up on a series of 57 lat transfers performed for irreparable supraspinatus and infraspinatus tears at 10 years. All patients attempted non-op management first, and irreparable subscap tears were excluded. 12 had teres minor failure and 17 had subscap abnormalities, but they were all repairable. 18% of them were salvage procedures for a failed cuff repair. At 10 years, 46 patients remained available for follow-up. At intermediate follow-up of 2 to 6 years, the simple shoulder score, constant and age and gender match constant scores all improved. External rotation, forward flexion, abduction all improved. All these changes were found to be maintained to follow final-up, follow-up, and 74% of patients were satisfied. The total reoperation rate was 12%, plus there was 2 patients that underwent reverse total shoulder prior to final follow-up. And there was a progression of hematograde as well as decrease in acromial-humeral interval from 7.4 millimeters to 4.9. Risk factors that they analyzed for poor satisfaction with the procedure included pre-op teres minor atrophy, being a revision procedure, having insufficient subscap at final follow-up, and undetectable lat activity on physical exam post-op, and also a critical shoulder angle greater than 36 degrees. While this design of the study was limited, it helped to elucidate exactly how much improvement can be expected from the lat transfer, more importantly, who might do poorly with it. A multi-center study from France and India prospectively followed a cohort of patients who they performed an arthroscopic assisted lat transfer. They utilized bone tunnels for fixation instead of suture anchors because it was felt this would help prevent early failure. And 30 patients had prior surgeries and all had fatty infiltration greater than grade 3+ in at least one muscle. And they all underwent an MRI 1 year post-op. At final follow-up, all outcome measures improved substantially, especially pain. 82% of them were satisfied, and there are no subject characteristics that place patients at an increased risk of dissatisfaction. However, patients with prior surgery did have significantly lower constant scores. 4 grafts failed, 1 went on to reverse shoulder, and 3 underwent revision surgeries for hematomas. This study benefited from its prospective multi-center design and was the first to evaluate arthroscopic assisted lat transfer with midterm data. However, the small sample size without a control group limits the ability to extrapolate this further. The same group performed a retrospective study 3 years later to evaluate modes of failure for these lat transfers. They, instead of doing a post-op MRI, they placed 3 metal clips along the tendon at fixed intervals of 2 centimeters in order to monitor the migration radiographically post-op. They considered a failure of fixation to be migration of metal clips by at least 2 centimeters. Similar to their prior study, the outcomes improved in all areas of final follow-up. However, there was a nearly 40% rupture rate analyzed on the radiographs. Most of those occurred at the bone tendon interface. No cortical buttons failed, but when stratified by repair status, those with ruptured tendons had lower outcome scores in all areas and were satisfied only 50% of the time compared to 95% of the group where it did not rupture. It was found that the ACEs scores decreased with increasing migration distance, and 7 of the 23 patients with ruptured tendons went on to reoperation. The authors postulated that their rupture rate was substantially higher than their prior series because anatomic healing is difficult to analyze on a post-op MRI, particularly with metal interference. And they proposed that this might be an explanation for the variable results published in the literature. Due to the imperfect vector of the lat tendon, the lower trapezius tendon has gained interest in recent years as an alternative with a more native vector. A biomechanical cadaveric study tested lower trapezius and lat transfers to various anatomic locations and tested their moment arms. They found that in adduction, the lower trapezius transferred to the infraspinatus insertion had the largest moment arm, whereas in 90 degrees of abduction, the lat transfer to the superlateral humeral head had the largest moment arm. This retrospective case series represents the largest cohort of lower trap transfers reported for massive cuff tears. They followed 41 consecutive patients for at least 6 months. Nearly half of them had pseudoparalysis pre-op with no improvements of motion with the lidocaine injection, and 2/3 of them had a prior failed cuff repair. All patients underwent an arthroscopic assisted lower trap transfer with an Achilles allograft. At final follow-up, 38 of the 41 had a palpable contraction of the trapezius muscle. Pain, forward flexion, abduction, external rotation, dash, and subjective shoulder value all improved significantly. 4 patients did not improve and underwent reverse. Factors that were associated with worse outcomes included symptoms for more than 2 years, hematograde 3+, and true pseudoparalysis. Prior surgery, teres minor atrophy, and partial cuff repair had no effect. These results helped to validate lower trap transfer as a treatment for these patients, particularly those who had failed prior repairs and pseudoparalysis. However, there were a number of limitations, including the retrospective design and very short follow-up period. On the anterior aspect of the shoulder, the irreparable subscap tears have been treated with tendon transfers from the pec. This review of 195 shoulders from 8 studies evaluated outcomes at least 6 months. They found that constant scores improved from 37 to 61 post-op, and they were significantly better in patients who underwent a subcoracoid transfer underneath the conjoint tendon. Range of motion improved in forward flexion and abduction, but remained the same in internal rotation and external rotation. And lift-off tests resolved in a majority of patients. Overall, the pec transfer seemed to improve the function, though the relatively low final constant scores highlight the salvage aspect of this procedure. Similarly, the protocols in each study were different. The next intervention we'll talk about is the subacromial balloon spacer. This is only really been in use for the last decade, primarily in Europe. It's a biodegradable polyactide copolymer that is arthroscopically inserted into the subacromial space to center the humeral head on and reduce subacromial friction. It does nothing to heal the rotator cuff, but rather it serves as a rehab accelerator and enhances the ability of the synergistic muscles about the shoulder to take over the rotator cuff function. It's designed to fully degrade within 6 to 12 months. And although it does not alter the rotator cuff tissue, primarily is advantageous in its minimally invasive insertion and lack of post-op restrictions. So the slings are generally only used for a week or two, and then the patients get immediately into their rehab. For this reason, this has been indicated particularly for patients who don't want a larger procedure or can't tolerate the post-op rehab protocols. However, some surgeons caution against using it with the massive subscap tear due to risk of anterior migration. A collaboration between Hopkins and a group from Italy evaluated 51 patients who they did this procedure with at least 2 years follow-up. Patients were excluded if they had irreparable tear, subscap repair, or pseudoparalysis, and all had a biceps tenotomy and cuff debridement. The constant scores improved from 27 pre-op to 77. A acromiohumeral interval increased immediately post-op prior to decreasing by final follow-up. Overall, 90% were satisfied with the surgery. 6 underwent a revision to a reverse or a lat transfer, resulting in an overall 87% revision-free survival at 3 to 4 years. So this demonstrated that the balloon spacer can have excellent outcomes in the short term. However, it seems that the spacer effect of the spacer resolves by final follow-up. So it's likely that any remaining functional improvements were not related to the spacer itself. Another retrospective case series from France evaluated 37 patients. All had biceps tenotomy and cuff debridement at the time of surgery with a follow-up of about 3 years. And at final follow-up, forward flexion, abduction, external rotation had all improved. Constant scores went from 39 to 64. And interestingly, the scores continued to increase from 1 year to final follow-up. However, the acromiohumeral distance again decreased from 8 millimeters to 6 post-op. Similar to the last series, this one showed that this can be a safe procedure with modest improvements in function and pain. However, it's still unclear how much of that comes from the spacer and how much comes from the biceps tenotomy. Again, it does not appear that the actual spacer effect is maintained at the final follow-up, as evidenced by the decrease in acromiohumeral distance. A recent systematic review analyzed 12 studies with 291 shoulders that received a subacromial balloon spacer with an average follow-up of 2 years. They found that the average constant score increased by 18 to 49 points. There was a wide range of satisfaction rates, however, from 45 to 100%, although there's only one study that reported satisfaction below 80%. Range of motion improved in some studies, but the type and amounts of improvement were highly variable. However, there was a low 2% complication rate, with only 3 out of the 291 shoulders having migration of the implants. Due to the large variation in study design, though, and patient selection criteria, it is difficult to say exactly how much benefit these balloon spacers provide, though it appears that the results are mostly positive with a low complication rate. Another newer option is the superior capsular reconstruction. This aims to replace the superior capsule by securing a graft directly to the glenoid and greater tuberosity, thereby preventing superior migration of the humeral head. It's gained popularity in the last decade. Similar to graft augmentation of the partial repairs that we discussed earlier, the superior capsular reconstruction uses primarily tensor fascial autograft long head biceps autograft or an acellular dermal allograft. And it's been found that increasing thickness and size of the grafts results in stronger constructs. Parts of the rotator cuff that can be repaired should still be repaired, and the graft can be then secured to that remaining intact cuff. Mihata was the first to describe the superior capsular reconstruction, and in 2018, he reported on the outcomes of his cohort of patients with a focus on return to sports and work. He treated 100 patients with arthroscopic superior capsular reconstruction using a fascia lata autograft over the course of 7 years. Preoperatively, 60 of the 100 patients either participated in recreational sports or had physically demanding jobs. At final follow-up, the average ASIS and JOA scores improved substantially, as did forward flexion, external rotation, internal rotation. Nearly all the patients who participated in sports or physically demanding jobs returned to their pre-injury level, and those who participated in recreational sports were found to have better improvements in their scores and range of motion. They had a complication rate of 16%, including 2 deep infections, 4 loose suture anchors, 2 contractures, 3 retorn tendons, and 5 graft tears. Though retrospective in nature, these results formed the basis for the increased interest in superior capsular reconstruction. The complication rate was not low, but most were not major. Overall, the functional gains and return to activity were extremely promising, though it's unclear from this study whether fascia lata autograft is the ideal choice, but he has reported great success with it with minimal morbidity. This multi-center retrospective study from Missouri reports on the outcomes performing arthroscopic superior capsular reconstruction with the dermal allograft, whereas Mihata performs his procedure with the arm at 30 to 45 degrees of abduction. These surgeons prefer to keep it in neutral to reduce tension. They follow their patients for 2 years. At final follow-up, the visual analog scores, ASIS and SANE scores, as well as active flexion improved at all time points. The acromial distance increased from 6 millimeters pre-op to 8 millimeters at 6 months, and then went back down to 6.7 by final follow-up. And MRIs post-operatively at 1 year showed that graft thickness was similar to pre-op. 57% had vascularity on duplex, and 67% appeared to be fully intact on MRI. They had 14% rate of complications, and there was only 1 revision to reverse. Though the sample size was small, this did demonstrate that the acellular dermal graft can be a viable option. A collaborative study from multiple countries retrospectively assessed a group of 80 patients who either underwent arthroscopic superior capsular reconstruction, including 40 using long head biceps autograft and 40 with dermal allograft. Of note, a much larger portion of the allograft group had prior surgery, and they also had worse active range of motion pre-op. For the biceps group, the tendon was tenotomized a few centimeters in the glenoid insertion, and then the distal edge was secured to the greater tuberosity and the remaining infraspinatus tendon. Most of the patients had an acromioplasty, and they were followed up for a year. And at final follow-up, there was no significant differences between the 2 groups for any outcome. The allograft group did have a higher complication rate and a lower rate of complete healing seen on follow-up MRI. And while this study showed overall similar improvements in both groups, it's difficult to draw many conclusions given that the groups were not similar at baseline and the dermal group had more prior surgeries. So a better designed study with matched cohorts would be needed to better elucidate the differences. Last year, a Turkish group performed a randomized controlled trial comparing lat transfer to superior capsular reconstruction. All the patients failed non-operative management, and patients with irreparable subscap tears or prior surgery were excluded. Those who underwent a lat transfer were augmented with fascia lata autograft, while the primary substrate in the superior capsular reconstruction was fascia lata. They were followed for 2 years, and they found that patients in both groups were similar at baseline. And there were no differences between the 2 groups in final range of motion assessment, but the superior capsular reconstruction had significantly better constant visual analog and ASIS scores at final follow-up than the lat transfer group. Only the lat transfer group had a statistically significant increase in acromiohumeral interval, though both groups were similar at final follow-up. And interestingly, while the lat transfer only successfully treated pseudoparalysis in 45% of cases, the superior capsular reconstruction was successful in 92% of cases with pseudoparalysis. The overall graft failure rate was 5% on follow-up MRI. So overall, this is a high-quality study that paired two of the most frequent salvage procedures for irreparable cuff tears. While both fared reasonably well, the superior capsular reconstruction appeared to have slightly better functional scores, particularly in patients with pre-op pseudoparalysis. So longer-term follow-up be needed to see whether these hold up or not. Also, one of our former residents, Jules, appears to have become an expert on this technique. I'm sure she'd be happy to walk anyone through it who wants to do it. When all else fails, the remaining option for irreparable cuff tears is reverse total shoulder arthroplasty. Prior to the advent of the reverse total shoulder, there really were not many options for patients who failed the other salvage procedures, particularly if they went on to develop a cuff tear arthropathy. Anatomic total shoulders don't work well in this population as they rely on a functioning rotator cuff. However, the purpose of the reverse is to medialize the center of rotation of the glenohumeral joint and thereby increase the moment of the deltoid to optimize its efficiency. Although the primary indication of reverse arthroplasty is superior migration of the humeral head with glenohumeral arthritis, particularly in elderly patients, the envelope continues to be pushed further and has frequently been used in irreparable rotator cuff tears without arthritis. Seems to be particularly useful in patients with pseudoparalysis who would otherwise obtain mediocre results with the other treatments, and patients with failed salvage procedures, anterior superior escape of the humerus and proximal humerus fractures, though that's beyond the scope of this discussion. Contraindications are patients aged under 65 years due to concerns for implant longevity, although as these implants become more durable, this is being performed in younger patients more frequently. Anyone with deltoid or axillary dysfunction or insufficient glenoid bone stock. In recent years, a lateralized design of the components have been used more often in an attempt to reduce scapular notching. This group retrospectively analyzed 2 matched cohorts who underwent reverse total shoulder with this implant. They included 34 patients with an irreparable cuff tear and 68 with cuff tear arthropathy. The cuff tear group was diagnosed on MRI with superior migration without arthritis. They were similar demographically, but the arthropathy group had a higher incidence of pseudoparalysis and lower pre-op ACEs and constant scores and worse range of motion. All the patients were at least 65 years old. At final follow-up, both groups had substantial improvement in all functional scores and range of motion, except for internal rotation, and no differences were seen between the groups. However, due to the lower baseline scores in the cuff tear arthropathy group, they had a larger magnitude of improvement in forward flexion and abduction. There were no radiographic differences between the groups, and scapular notching was seen in 12%. The authors concluded that this had similarly good outcomes for elderly patients, both with and without cuff tear arthropathy, and having the matched cohorts helped to validate their results. Another study from Austria aimed to determine whether a prior failed arthroscopic rotator cuff repair surgery would affect outcomes for a reverse shoulder done later. They prospectively followed 2 cohorts, including 29 with a failed cuff repair and 39 with a cuff tear arthropathy for 2 years. And at final follow-up, there is significant improvement in all functional scores in both groups, with no differences found between the 2 groups. Active forward flexion and abduction improved substantially in both groups, and no changes in external and internal rotation were found. There were 4 complications in each group involving radial neuropraxia and loosening of the implants. There's no difference in scapular notching, and interestingly, complication-free survival was 97% at 2 years, but only 65% at 7 years. So this study showed that the patients with a prior failed rotator cuff repair will have usually similar outcomes after reverse compared to cuff tear arthropathy without prior surgery. However, there was a substantial late complication rate in both groups. And despite the improvements in functional outcomes, the results from reverse still only reached their fair constant scores compared to a normal shoulder. As surgeons continue to push the boundaries of reverse shoulder arthroplasty, a Swiss group reported on their outcomes in 23 patients who underwent a reverse prior to their 60th birthday with an average of almost 12 years of follow-up. 65% had a prior surgery and 22% had 2 or more prior surgeries. 52% of the shoulders were cemented and the rest were uncemented. And three of the patients actually had a concomitant lat transfer for external rotation loss. All of the scores improved from baseline and were sustained throughout the follow-up. Prior surgery did not seem to affect the scores negatively, but did correlate with higher pain levels. They did report a complication rate of 39%, but said that there was no difference between those with and without prior surgeries. 95% of the patients had scapular notching by final follow-up, and the reoperation rate was 26%. Overall, there were modest gains in function here that were sustained for the full decade of follow-up. However, there's a substantial complication or reoperation rate and an astounding number of patients with scapular notching. So this paints a gloomy picture for this surgery in young patients. However, it should really be noted that this was a small heterogeneous group of patients that was collected from 1997 to 2008. And there have been many important advancements in this procedure and technique since then. So an update on outcomes with modern technique and implants would be beneficial. And then with varied results reported for reverse in this patient population, a group from Florida evaluated their cohort to identify risk factors for poor functional improvement post-op. And 2 cohorts were created based on simple shoulder test improvements of greater than or less than 2 points. And all patients were followed for 2 years. And they found that patients that improved in simple shoulder test scores saw much better improvements in their ASIS score, forward flexion, and self-rated function. Risk factors associated with poor functional improvements included a high pre-op simple shoulder test score because they were already doing well, ipsilateral neurologic dysfunction, age less than 60 years, and major post-op complications. While the reverse can be a great option for many patients with irreparable cuff tears, this study showed that there are some patient populations in which caution should be taken, particularly those young patients who have pretty good preoperative function. However, this is a retrospective study, and larger prospective trials would be needed to confirm these findings. All right, so now that we have gone through all that data, we can try to boil this down into a more digestible treatment. You will be tested on this next slide. All right, you got it? Great. So here's a flow chart that I put together just to serve as a suggested blueprint for patients over 65 with a massive irreparable cuff tear. If they have substantial arthritis or anterior superior escape of the humeral head, it's indicated to perform a reverse total shoulder as a primary treatment, particularly if they've already failed conservative measures. If there's no arthritis, but they have true pseudoparalysis, it could be reasonable to go straight to a reverse for someone who's low demand and has appropriate expectations. However, due to the high complication rate and the risk of long-term implant failure, alternative options might be chosen as first line, particularly in higher demand people. When there's no pseudoparalysis, therapy with or without an injection should always be the first line treatment, with about half of those patients recovering enough pain and function to avoid surgery. If non-op treatment fails and the patient has continued pain with good function or can't comply with substantial rehabbing, an arthroscopic debridement can be performed with the addition of an optional adjunctive treatment. And then if function is not maintained and a partial repair can be performed, this can be done with graft augmentation. If function is primarily absent due to an irreparable subscap or an infraspinatus and teres minor tear, a tendon transfer can be considered for high demand motivated patients. If function is poor and there's no cuff available for a partial repair, superior capsular reconstruction can also be performed for high demand patients. And then when all else fails and for low demand patients who won't tolerate extensive post-op rehab, the reverse shoulder remains as the final salvage. This changes a little bit for patients under 65, especially those who are very high demand. If there is substantial arthritis or anterior superior escape, attempts may be made to delay reverse total shoulder, although this ultimately may be the only option for them. If there's no arthritis and they have true pseudoparalysis, a soft tissue procedure should be performed, either a partial repair with a graft augmentation or a superior capsular reconstruction, which might have a better chance of success with pseudoparalysis. And then some surgeons even now will skip these and go straight to the reverse. If there's no pseudoparalysis, non-operative management and arthroscopic debridement are not as likely to result in an adequate outcome in a young high demand individual. The remaining options are similar to those discussed on the previous slide. However, every effort is made to restore function with the soft tissue procedures prior to resorting to reverse total shoulder. And then finally, no two patients are the same. These decisions all have to be tailored to each patient based on their needs and expectations. And as advances in these procedures continue to be developed, it's likely that the directions of a lot of these arrows will change. So let's go back to our cases real quick. The first patient was the 56-year-old with the acute injury and suboptimal MRI slices. They underwent arthroscopic, intraoperatively, there was a complete rupture of the long head biceps. There was a partial thickness subscap tear, massive supraspinatus and infraspinatus tears with retraction to the level of the glenoid, all of which were able to be repaired primarily. However, the rotator cuff footprint was medialized 5 millimeters to reduce tension and was partially uncovered. So a collagen patch graft was applied to aid in healing. Subpectinodesis was also performed to the biceps. These are just some intraoperative images showing the massive tear and the eventual subscap, supraspinatus, and collagen graft. The next patient was found intraoperatively. An open procedure was performed, acromioplasty and biceps tendoni were performed. And after assessing the rotator cuff, they were able to get enough excursion with a interval split there, but the supraspinatus, when it was repaired to the tuberosity, was not able to entirely cover it. And for this reason, the biceps tendon was grafted on top of it to facilitate healing. Our next patient, our 77-year-old male, underwent an arthroscopic evaluation and underwent a subacromial decompression, and then was found that the cuff tendon was not able to be mobilized enough to cover the entire footprint, and an acellular dermal allograft was incorporated to cover the rest of the defect with an open repair. And then the last patient was the 65-year-old female who had a re-tear of her prior repair. And she underwent an arthroscopic subacromial decompression and tenotomy. Her tear was deemed too large and immobile to repair primarily, and her subscap was able to be repaired, but the supraspinatus underwent a partial repair with a dermal allograft. So in conclusion, massive irreparable rotator cuff tears can be a large problem, even if they are technically repairable. However, the truly irreparable tears still do not have a gold standard solution, despite many options now. It's important to stress that we as surgeons are not very good at predicting which cuffs are going to be irreparable preoperatively, and not all massive tears are irreparable. Thus, the surgeon must be prepared with a contingency plan prior to setting foot in the operating room so that they can make the appropriate decisions intraoperatively. Many of the procedures that we talked about are not possible without special tools and grafts that need to be arranged for ahead of time. It's important to emphasize that although there are multiple effective treatment options for these injuries, patient selection is critical, and no single treatment's right for everyone. Thankfully, our available salvage procedures are much better now than they were a decade or two ago, but there's still certainly a lot of room for improvement. So moving forward, the holy grail would be to find a way to get the biology of the rotator cuff back to where it was. And there's a bunch of lab and animal studies in process for this. Outside of this, we would benefit from more prospective randomized controlled trials. That is difficult because we don't know what we're going to do when we enter the operating room with these patients. Specific questions that still remain include what's the ideal graft choice, what types of repair are more likely to fail, whether the lower trapezius or lat transfer is better, how to enhance the fixation techniques for a transfer, whether any of these existing techniques can be combined to enhance the results, and how the modern reverse shoulder replacement systems would perform in young patients. So I'll take any questions now. Thanks everyone for being here. And then also thank you to everyone who contributed, including all the upper extremity faculty and all the patients who gave us their cases.
I have some comments and questions. First, that was probably the most thorough discussion I've ever heard on rotator cuffs, small, medium, large, massive, all tears, all concepts. So that's a job well done. And it's a lot of information. I think the most important takeaway should be that these massive irreparable tears in most practices, fortunately, are rare. So we're talking about a small subset, although it's a complicated topic, it's a small subset. So I think if someone's doing really acute tears in young people and having trouble repairing them, to me, that shouldn't really be a problem. So if you have edema, an acute tear, no atrophy, no fatty replacement, even if it's massive, in almost every case, that should be repairable. The question is it acute on chronic? And then it becomes a more difficult problem. So in a 50-year-old person who truly has an acute episode, they should be repairable. And I don't know why it wouldn't be. I think technically you have to do what you do best, but they should be. Even chronic ones, more often than not, are repairable. So I think that, to me, that's a very big thing. The other thing is the difference between traumatic and degenerative tears. And again, younger people who have traumatic tears are different than older people who have just degenerative tears. The traumatic ones, it's a different type of tear, and conservative care can work. I'm a little skeptical about injecting people. You make it sound like it's, a common thing you should do. And I feel like injecting steroids in a person that has a tear, particularly a young person, nobody's really done the research on that and whether or not that affects the healing. We already know, and you've explained it very nicely, that the biology of healing is very difficult. I would be a little skeptical in young, active people where you might consider doing a repair, automatically injecting steroid, which has a degenerative effect on tear and might, and again, the research isn't there, affect the results of a repair done later on. Otherwise, I think when you see a million different choices for a massive tear that's irreparable or might be irreparable, it tells you that we don't really have an answer, but your review of the literature was excellent.
Thank you. So for your last point, I agree that if there's someone who you think you might be doing any sort of procedure on later, that a steroid injection probably not the best thing to do acutely. And that's why I kind of dotted that section out for the patients under 65. It's really would be more for pain relief and someone who you have no intention of ever operating on. And then for your comment on the vast majority of these being repairable, I think that's definitely true. I think in recent years, as we've learned that in follow-up, that a large portion of these tendons don't truly heal to the tuberosity, even if they have good outcomes. I think that there's been more interest in determining what is better for healing or better for patients in terms of a high tension primary repair or a lower tension augmented repair that takes off that tension, maybe increases the rates of or decreases the rates of suture anchor pull out and pull out through the tendon. So I do agree with you that the vast majority of these can be repaired, but in the recent years, there's been more interest in determining whether that's always the right choice.
Yeah, I agree with you. That's a different talk. A massive tear that's irreparable is different than a tear that's repairable, but you are concerned about healing. And that presents the issue of whether the quality of the tissue is good, whether the bone quality is good, whether, there's a lot of issues on healing, whether there's tension. Clearly, there is no tendon in the body that heals well under tension. Those are separate issues, but I think the irreparable ones are different than the repairable ones that have poor prognosis because the biology and the situation won't allow it to heal. So I think differentiating that is very important. Some are irreparable. You cannot get it back. It's rare. Those go through the algorithm that you're presenting. Many can go back, and if there's a chance of it healing, there's nothing better than your own, but there are issues that may prevent it. Thin, horrible rheumatoid tissue, horrible bone quality. But I think that's a separate issue. You're talking about massive irreparable rather than massive tears that are repairable, but factors may not be favorable for healing.
So Dave, I have a question for you. I agree with you that a lot of tears, if you work hard, become repairable. In my hands, I just tend to open them because I feel like I can do better mobilization of the cuff and just spend a lot of time with mobility, but when I'm all said and done, a lot of times the tissue quality doesn't look great. So what's your opinion on putting a patch over those tears that you work really hard to repair, but you know the repair is, I'm going to say, moderately tenuous at best?
I'm personally not in favor of it because I think the studies are varied. I don't think there's enough of them. I don't think they're good enough. I've used them before. To me, if you can't get the tendon without significant tension repaired with good quality tissue, probably whatever you do is going to fail with regard to a repair. I mean, people are using it. Obviously, it's a big market. To me, that's not a good sign. Okay, in any tendon, in any body part, particularly the rotator cuff. So I agree with you, and I do work hard to repair them, and I'm not good enough to do it through the scope, so I do it open, but people are good enough to do it through the scope. It doesn't matter how you do it. If you can mobilize it without significant tension, even if you medialize it and the tissue's good, that's your best chance. And again, the biology may not heal, but I think you have your best chance. I think that's an issue that people have to decide for themselves, whether they're going to put a patch on it or not. And some people put them on. I don't think we know for sure. And I'm not convinced that's the answer, but that's debatable.
Go back to maybe like your second case or something. I just want to go over your MRI. Might be your second. I don't really remember.
This one.
Yeah, that's a good example. So what's the history on that patient?
This was the patient who was 72 with just chronic shoulder pain and weakness.
There was one who was a little bit older who fell. Maybe it's the next one. Maybe it's your third.
Yeah, they say they fell.
There we go. Try that one. Sagittal. Can't see your sagittal particularly well, but because it's a little, there's too much light in the room, but I can see it on my computer. But if you look at the supraspinatus fossa, look at that case and look at your last case. And look at, although you don't see a lot of fatty atrophy or fatty infiltration of the supraspinatus tendon or muscle belly, look at the amount of space that the muscle itself takes up in the supraspinatus fossa as compared to being surrounded by fat. And I think
It's still atrophic.
Right. So I think when you see that, you pointed out appropriately that we're poor at predicting the repairability of these tears. And with Dr., I always look at these and say, well, is there going to be something that I can mobilize and put back? I find that when as that volume there, the muscle belly volume even doesn't have a lot of fatty infiltration, but the volume is small, that is a very difficult tear to repair. And you have to be prepared to not be able to repair it.
Yeah, and Charlie, I think a big issue when you have retraction is sometimes magnets don't go medial enough. And when the tendon retracts, the muscle retracts, and where you think the muscle should be is more medial, and sometimes you're not sure. So if you look, as you go more medial, the muscle may become more apparent or may not. So I think you have to be careful when you look in that fossa. So you're looking at the muscle for atrophy and fatty replacement. And if you don't go medial enough, and a lot of people don't go medial enough on their MRIs, it's just the protocol, and then you can't tell. But if you
Go
have
back to the last case,
Or the
the
one
one prior, the one prior, because it shows the picture better. Just go back to the previous case. I mean, look at that. Would you say that supraspinatus has fatty infiltration?
the best way to tell about the muscle is on a T1 sagittal image. That's the best way.
Bottom right.
Yeah, so to me, it looks like there's, and again, I'd have to see more cuts, but it looks like there's atrophy. But within the muscle itself doesn't look bad. And normally when you see fatty replacement, it's not just on the outside, it's within the muscle. So to me, I'm concerned that I'm not going medial enough to see the muscle. If you're convinced that there's a lot of atrophy and fatty replacement, that's not going to do well. I agree with you.
But see, that's my point though, is like, I'm not talking about fatty, there's fatty infiltration. So the muscle looks like marbled, beef, right? As they talk about Gotalier and 1, 2, 3, 4. But when you look at that, there's not fatty infiltration, but the volume of the fossa is completely taken up by more fat than there is muscle. And that's to me, that's an acute on chronic. And I'm just saying, in trying to predict repairability, I find that the smaller that muscle belly is, regardless of fatty infiltration, in the muscle itself. It's the fat around it. There shouldn't be so much fat there.
Right, but what I'm saying,
patient-
you're right, Charlie, but what I'm saying is, if you were to go more medial and look and it stayed like that, I agree. But when the tendon pulls back, the muscle pulls back, and where you think the muscle should be at its maximum, it's not. And so it can confuse you. If you look at the infraspinatus and teres minor, you can see within the muscle, there's all this white stuff. And you can see where the muscle is at its maximum, that there's issues in those tendons. I don't yet see that in the supraspinatus. And I think people misread that a little. And that's,
Well, you just have to look at the
I agree with
you just have to be
you.
careful. Look at the coronal, look at the upper left-hand picture. And the whole point is, if you're cutting in sagittal section at the myotendinous junction, when you're cutting at the spinal glenoid notch or the takeoff of the scapular spine, you're not hitting most of the muscle belly. Like if you look at that coronal, the muscle's pulled way back. So it's not as bad as it looks on the sagittal. I mean, it's atrophied, but you can see, depending on where you cut the cross section on that coronal at AP slice in the upper left, you can see more or less muscle. So it's small, but it's not that fatty infiltrated, and it looks small partially because it's pulled back. I think people understand that, right? Like, you got to be careful on the sagittals, what you're really cutting through. You can see on the coronal, the muscle belly gets fatter as you get more medially, and on the sagittal, you're just not proximal enough. So it's small, but it's partially looks small because it's pulled back.
no, but Rob, I think people look at the sagittal, which is the.
I know, but you got to be careful. Like, look.
I know that's the point. The point is, you really don't get the view you want on T1 because a lot of protocols don't go that medial. That's why.
But also it can be pulled back so far. Like Charlie, I mean, whatever I'm saying is correct. That's not filling enough, but you might not be medially enough. And you can see it's pulled back so much. Look at the myotendinous junction. It's medial to the glenoid, medial to the superior glenoid. So it's well.
But where did all the fat come from? That fat didn't just magically grow there in 2 days.
I think that's part of the retraction of the muscle. I mean, the fat just fills in, as the muscle retracts back.
It's definitely small, but it's not as, you got to be careful. You just got, I mean, I think that's also a sign also, Charlie. I don't know, part of it is the muscle fatty or atrophied with the more fat around it, or also is it so medialized, but it's hard to mobilize and pull out and get it fixed. Is that also a case?
That's all I'm saying is that when you see that, because look at these cases, these are cases of irreparable tears. And I would look at that even on the coronal, like Dave, you're both pointing out, the coronal, the muscle looks good. And I just know going in that is going to take a lot more. You're just not going to grab that and pull it back. I can guarantee you that. That's going to be work to get it where it belongs. And you just have to know that going in, because there's a patient who said they fell 2 months ago. 2 months ago, you should be able to walk, you should be able to grab the tendon and pull it back. That's not going to happen in that case. That's all I'm saying.
Right, but Charlie, the first case was a 50-ish-year-old guy with an acute injury, and they couldn't get it back. That doesn't make sense. A 50-year-old guy would know if he had a chronic problem, right? So, and it looks similar, and so I think you have to take the history.
Here first.
You have to take all these things, and even with everything taking into account, it's hard to figure.
Said it was 1 month, but has fatty infiltration.
Todd, congratulations. That was an exhaustive but really good review. I'm going to preach to the choir. I don't have an argument with really anything that's been said either. I would point out the bias in your talk that the only pictures that you have are arthroscopic, because that's the most pictures that we take, and most of these are done open. We just don't usually take pictures of the open ones so much, so it's an understood bias. I would echo just a couple things. I don't use the dermografts so much. I did try that early on in my career, and I didn't have a good experience with them. I'd much rather use somebody else's, or somebody's own tissue. The biceps is if it's available. I'm not against doing the superior capsular reconstruction, and I think in many cases you can do that with tissues that are there. But if you need to augment it, I think that's something you just have to capitulate on. But you're not trying to get function as much as you're just doing interposition arthroplasty. And I think that's the same whether you're mounting up whatever tissues are there or putting an implant in there. But yeah, I think it's a complicated problem. And as you pointed out, clearly not all patients are alike, and you need to sort of not just pick the right patient for the right procedure and vice versa, but set expectations. I mean, I have one lady right now, she's awfully nice. She speaks Italian. She speaks better English than she understands English. And it worries me that when I tried to set her expectations, I didn't do a good job. She's got a really good result from a pain perspective, not so much function, which is kind of what you would expect with some of these big massive tears when you put the biceps graft in there. But she's unhappy because she was expecting a normal shoulder, and I didn't do a good job explaining that to her. So I think it's not just selection, but it's letting them know that they're not going to have the pitching job for the Yankees when it's all said and done.
Right.
Just so everybody knows, that biceps autograft that everyone's writing about these days, Dr. Michael Coyle was doing that when I was a resident. So that's about 30 years old. Nothing new.
Biceps is always.
Yeah. And I would also say, I mean, I'm
Dave.
happy that it's not very common in Dave's practice, but I tend to see a lot of these for some reason. I guess it's just people just find you when they have these big bad tears. But it is a good technique to know how to do a couple of different things. Sorry, it's good technique to know a couple of different things because no two are the same.
All right, I'm going to stop it there for time's sake so everyone can get on with their day, but thank you all.
Good job.